All right. So we're gonna get started here. Welcome, everyone. Thank you so much for joining us for this month's seminar. You're joining the Brown Lifespan Center for Digital Health. My name is John Patania. I am the program director here at the center. For those who have not joined before, the CDH is a collaboration between Brown University and Lifespan Healthcare Systems. We're here to facilitate the development and dissemination of effective and equitable digital health tools that make a difference in the health of patients and populations. As part of a number of strategic initiatives that we have, one of them is to educate and build up the digital health workforce. And part of that initiative is through these webinars. So it's my pleasure to welcome Dr. Geoff Capraro, who will be talking about NaloxBox Internet-of-Opioid-Things. Dr. Capraro is an associate professor with Brown Emergency Medicine and a pediatric emergency medicine subspecialist. He co-founded the NaloxBox program for public access naloxone so that laypersons have the tools and information they need to rescue individuals experiencing an opioid overdose. As always, our presenter will have about 40 to 45 minutes to present, then we'll close out with any questions and a Q&A function at the very end. Please feel free to put in your questions in the chat and throughout the presentation, and I'll take note of them. Thank you so much, Dr. Capraro. We're so excited to have you here. Over to you.
Great. Thank you, John. Yeah, thank you for the Center for Digital Health for inviting me to share my and Leo's pilot project involving technology enhancement of opioid overdose rescue boxes named NaloxBox, and some related activities. We're greatly appreciative of the work that CDH does, the way it brings together people from a variety of disciplines to consider how rapidly evolving technologies might be integrated for better health outcomes. I'd like to start by acknowledging those who have supported this and related work, and specifically the original NaloxBox pilot projects in 2017 were supported by mini grants from Rhode Island Department of Health. From there, I received assistance from Social Enterprise Greenhouse in Providence, which provided me social impact and venture knowledge and training. And presently, the National Institute of Health, National NIGMS COBRE on Opioids and Overdose is supporting the NaloxBox Plus pilot study that's the center point of this discussion. We also are thankful for the support of Brown Emergency Medicine for an SRA, or Summer Research Assistant student, Joanne Liu, in her good work this summer. And regarding disclosures, I did co-found NaloxBox. The program is run by the nonprofit Rhode Island DMET Medical Reserve Corps, and I have no financial stake in NaloxBox. So I'd like to overview a few different items during this discussion briefly. Naloxone, public rescue, and the NaloxBox program. Apologies to those of you who are familiar with that already. I want to give some sort of background on how we got here. Opioid rescue training, the goals of the NaloxBox pilot, NaloxBox Plus pilot, and the NaloxBox pilot plus progress to date. That's impossible to say. Think about IoT tools in healthcare arenas, and then also thinking about what else Rescue Box might deliver. Pictured here is naloxone nasal spray, brand name Narcan. It's a generic version, and prior to that, there were syringes with nasal aspirator plungers on them to deliver naloxone, this highly effective wonder drug, into the nose of people experiencing overdose to prevent death. Naloxone is a fantastically effective antidote for opioid overdose. It competitively antagonizes opioids and can restore consciousness and breathing if only it is given promptly to a person experiencing opioid overdose. Despite many tiered and vigorous efforts to address our nation's opioid crisis and reduce opioid deaths, these deaths only continue to climb, most recently claiming 68,000 plus people in the United States last year. Unfortunately, there continues to be a great need to focus upon naloxone and improve upon its implementation. While vigorous and prolonged efforts to address the opioid crisis might need to continue, naloxone remains a central and lead component in the effort to reduce overdose deaths. When compared with a range of opioid interventions, existing evidence supports that the availability of naloxone is the most effective intervention for reducing opioid deaths. In the study, the authors modeled impacts of various interventions on opioid mortality. Naloxone is not a panacea, but this table demonstrates that the greatest number of overdose deaths, 21,000 over the next 10 years estimated, will be accomplished by optimizing naloxone availability. The table also shows that naloxone efforts must be paired with other evidence-based interventions to maximize lives saved. Most of the evidence-based practices for reducing deaths, unsurprisingly, are focused on the needs of people who use drugs, medication for opioid use disorder, psychosocial treatment, judicious and appropriate acute pain prescribing, and additional harm reduction measures such as needle exchanges, safer drugs, and getting rid of unused opioids. So if a person is using opioids and at risk for overdosing, how are they or their family members or loved ones supposed to get it? Naloxone is a prescription drug, and so writing a prescription to a person at risk for opioid overdose is a tried and true method of obtaining it. Co-prescribing with opioids to people who are receiving opioid prescriptions or people who are using recreationally, to those with opioid use disorder, to those in recovery or those recently released from prison, or people who are using other sedating drugs such as benzodiazepines, alcohol, or even stimulants, as the whole recreational drug landscape has now been contaminated by fentanyl. These prescriptions usually require an in-person medical encounter and a cognizant and caring provider, and frank discussion, and almost always an additional trip to the pharmacy. So there are some barriers to doing prescription naloxone. Street and community outreach is the mainstay for distributing naloxone because it provides a robust, lower barrier method of getting naloxone into people's hands. And it also provides a way to engage people using drugs with other useful interventions. Emergency use of naloxone and leave-behind programs from first responders address immediate and future needs for timely response. And pharmacy standing orders have been adopted in many states and improve access by removing the need for personal prescriptions for naloxone. But the act of requesting naloxone at the pharmacy, required copays, and inadequate stocking of naloxone can prove additional barriers. Finally, naloxone can be furnished as a public rescue asset in vending machines or naloxone boxes. This is a very low barrier method to obtaining naloxone and also can help to improve awareness and can be linked to trainings in overdose rescue. Local experience and a national survey of our NaloxBox program have demonstrated that naloxone furnished in public places this way save lives. I'd like to share two studies that address the public placement of naloxone for layperson use. Investigators in Boston asked if we pre-position naloxone in public places, would members of the general public be able to accomplish the steps of rescue, and could they do so in a time frame that results in naloxone administration earlier than it would be given by paramedics? So they conducted a sidewalk trial of simulated naloxone rescue. They demonstrated that even in Cambridge, Massachusetts, where the average municipal EMS run times is about 5.5 minutes, naloxone could be successfully accessed, even from a locked unit, and delivered by laypersons a couple minutes ahead of the arrival time of the ambulance. The timeline along the lower portion of this graphic demonstrates when participants accomplished key tasks. Excuse me. One can see that the simulated dispatcher was contacted at a median time of 48 seconds, the locked box was unlocked at 138 seconds, and naloxone was administered at a median of 189 seconds, which is a couple minutes ahead of the time of the ambulance would have arrived. And even when EMS crews arrive, they need to make their own assessments and obtain the treatment and give it, which would require additional time delays. So time matters significantly because a person overdosing is deprived of oxygen, and bodily injury and death will result without intervention. When community naloxone is provided without a lock or code, response times could be even faster from a layperson. Different localities would need to consider whether naloxone should be open, access, or locked, and the ideal locations for placing naloxone within their community. Another study related to pre-positioning of naloxone as a community rescue asset was also conducted in Cambridge, Massachusetts, and sought to identify how much geographic clustering there was in opioid-related EMS runs in order to strategize the placement of community naloxone. It identified 3 geospatial clusters for pre-positioning of the public access naloxone. They concluded that naloxone placed in those clusters will result in naloxone being accessible within 200 meters for 40% of the EMS runs. So cluster or hotspot data may or may not be available to everyone wishing to seek to deploy public access naloxone, but even in the absence of such high-end data, conversations with EMS responders and people doing harm reduction work in the community can provide some good locations for intervening. This sobering graph is what we were up against. In 2016, I asked a pharmacy colleague who was also volunteering on the rescue task force of the governor's task force for overdose, why are there no public access naloxone boxes? And he said, there should be, and why don't you go do it? So that was my challenge, and I reached out to people for help. I collaborated with RISD industrial design professors to create NaloxBox, and we secured those Department of Health mini grants to build and implement them in Rhode Island. The first iteration is shown here. This is the very low-tech version of the talk, portion of the talk. Naloxone is the NaloxBox contains naloxone, in this case intramuscular, provided by the Prevent Overdose with the Naloxone Intervention or PONI program at the Miriam Hospital. It also has a mask for administering rescue breaths if desired. NaloxBox, for better or worse, was not a research study, but instead a simple public health intervention. With the Department of Health funding, we had free boxes in hand and reached out to organizations whose clients were at risk for overdose, those in transitional housing from prison or homelessness, those in shelters and using soup kitchens, those in job training programs and recovery houses, and also public facilities such as libraries, municipal buildings, and public housing. Even though most of these organizations had some sort of overdose plan, like storing it in the manager's desk, they welcomed the public-facing units, and naloxone now appropriately was seeing the light of day and accessible to all. We paired the installations with infographics showing signs of overdose and steps of the rescue. One was designed for intramuscular administration and the other for intranasal, and we had English and Spanish languages represented. A Brown intern helped with our design. We also paired these installations in Rhode Island with on-site trainings for staff and clients. And pictured here are Anna Jane Gilkin, who was doing a lot of the library outreach, and Aaron McDonough, who trained virtually every police officer in the state through Rhode Island DMAT and NOPE RI program. And then to the right is Michelle McKenzie doing a training for staff and clients at Amos House, which is the first place we placed NaloxBoxes. They had solutions, but really welcomed putting these public-facing boxes in their facilities. And these are the warriors of the opioid crisis, people doing the street outreach and doing opioid education and naloxone distribution work, or OEND work. We installed 62 boxes around the state and enjoyed support from Department of Health and the Prevent Overdose Rhode Island program, which is really remarkable. If you've not visited their websites, they continue to really knock it out of the park on public access to interventions and also some surveillance of what's happening in our state. They integrated the locations in the NaloxBoxes on their mapping, and these maps also included the sites where people could obtain pharmacy naloxone. So from our Rhode Island pilot, we had received press first through Brown University and then the Associated Press syndicated story. And this led to a lot of press around what we were doing and our call for greater community engagement in rescue. But the quote that we valued the most was the confirmation of our first community NaloxBox mediated rescue from one of our early adopters. And hearing all this, we have responses from out of state, but we had a small grant from Rhode Island that we'd already depleted all the funds. And we really didn't know the way forward if we wanted to continue to distribute NaloxBoxes to other states. I had no experience running a business. I didn't run a nonprofit. And so I learned about the Social Enterprise Greenhouse in Davell Square in Providence so that I could undergo some training and thinking about what a social impact venture would look like and how it might be run. I completed their program in the fall of 2017 and then had discussions with my friend Aaron McDonough at Rhode Island DMAT and Brooke Lawrence about whether they had an appetite for taking over the NaloxBox program within their nonprofit. They were deeply committed to building stronger and safer communities, and Brooke appropriately characterized the opioid crisis as a slow rolling disaster. And they rolled up their sleeves and we got to work. Initially, actually working with Amos House, their jobs training program, and producing the first year of NaloxBoxes. This map demonstrates some of the geographic spread as NaloxBox spread far beyond Rhode Island. To date, over 2,000 NaloxBoxes have been shipped to over 300 buyers across the country. We have some data back on a retrospective survey from participants that the boxes are being used. Surprisingly, they're not having major barriers to restocking the naloxone. Provision of naloxone was not part of the program. We left it to people to solve the stocking and monitoring of the boxes to their own staff and their own funding agencies. Many of the purchasers actually wanted to buy more boxes. And we did learn some things that drove the NaloxBox Plus proposal, such as there was no routine inspection going on of the boxes. And these are, cash-strapped and staffing-strapped organizations. So there are ways that their jobs could be made easier with the addition of some technology. We had made some earlier attempts to add technology to the NaloxBoxes in 2017 that didn't go real well. Social Enterprise Greenhouse actually connected us with the nonprofit arm of GE, where people gave pro bono time for thinking about IoT solutions in an Arduino-based system. And they also helped us with some supply chain work to help Rhode Island DMAT think about how it might reconfigure how it's assembling the boxes. Given that input, we now were ready to move forward with our own next attempt at adding technology. I am learning as I go with a lot of these things, and IoT in healthcare, has some major pillars, sensors of environment or individuals or physiology, or med compliance. It's pretty broad. Also resource managing and communications. There are major applications, developments that need to integrate information coming from end users and managers of care. There's also significant security issues around confidentiality and privacy. So there are all we need are brains and hard work, and I happen to be working with a guy who's pretty strong in those departments named Leo. Leo Kobayashi pitched at the NaloxBox Plus pilot at the COBRE's hackathon last fall, and subsequently we were able to secure pilot funding to conduct this NaloxBox Plus trial, in which we propose to design, build, implement, and test IoT boxes. And the goal here was to assure proper stocking, replace the burden of physical inspections, and message owners when expirations were coming up, and also when the units were accessed. We also had the ability now to map the units' geolocation services with status reports on the maps. So welcome to Leo's garage. A magnetic read switch here would trigger a cellular network mediated message to facility staff so they can know if and when a box was accessed, so they can go restock it. In time, it's hoped that we'll be able to assure instantaneous messaging, but right now we're doing batched reports at time intervals that are longer than instant. And the idea that in a future iteration, if those are messaging well, you could summon staff assistants on the spot to help with somebody who's accessed the box. So there's a significant improvement in situational awareness, but at the least, what we're looking to deliver this year is reporting that the unit needs to be inspected and restocked. The backend web app can also monitor battery life and calls home to the web app, and also generate messages regarding upcoming medication expiration dates. Together, it's hoped that the NaloxBox offerings will improve facilities preparedness and situational awareness. Here is one of the units that's in Providence City Hall. The progress to date is that we've designed, built, and tested the proposed 25 devices. We've surveyed the owners of some of the 2017 installations. We've installed 12 devices in August, and Leo's been working on the web app and upgrades of the software so that 90% are calling home daily. He's updated the code early in October and captured one box opening event so far. We have 13 more that need to be deployed. I should mention that there's a reporting system that's integrated with this, whereas NaloxBox is not conducted as a trial. The NaloxBox Plus is a pilot study where we can have event reporting by scanning a QR code within the box. And this would have no PHI, would just report, was the box opened or vandalized, what was taken from it, was it used on a person, what was their status, were rescue breaths given, was an AED accessed, some things that are just generic information without PHI. So NaloxBoxes should be considered a community rescue asset, and each box's location can be mapped, so the unit readiness can be assessed, and also neighborhood preparedness can be known. We believe that the physical presence of NaloxBoxes not only helps get more naloxone into hands, but also increases awareness and knowledge and serves as inroads to stigma reduction and for the general population. The cellular communications should enhance risk group preparedness and situational awareness and can provide some metrics on usage. And the QR code deployment could expand rescue knowledge and facilitate event reporting, provide linkages to harm reduction and other helpful services, and facilitate community engagement and stigma reduction. I found this work extremely collaborative. The Rescue Task Force and Department of Health, it's amazing what the people do. They come from all different disciplines, and with a tight focus on trying to move the needle, trying to improve the health of the people we serve. There's also been tremendous collaboration across disciplines. I mentioned industrial designers. Joanne Liu is our biomedical engineering undergraduate. We've worked with other undergraduates on some of the other offerings that are paired with NaloxBox. And I'll share just a couple of these before we close here. This QR code links to a landing page for a few of the digital products that I've co-developed with a woman who's a drama therapist. She was working on community stigma reduction program in Rhode Island and a program called COAST, and now it's called Second Act. And we also then were engaged the SciTunes program at Brown University. SciTunes produces productions in the order of like 5 or 6 minutes long, which take a discipline in science and medicine, or maybe any discipline in undergrad, and then drills down into why this is an interesting topic, what's being done at Brown about it. And so they were kindly invited a collaboration on creating an overdose rescue video. And so we went through the process of drafting and then composing this cartoon for opioid overdose. It's a little bit longer than you might look for a really quick TikTok type moment, but it's fairly in depth, reviewing what opioids are and naloxone and how naloxone works, and then also the signs of overdose and steps needed to intervene effectively. So I encourage you to maybe scan that and take a look at it once we're wrapping up, if you like. This landing page also has two-minute video clips from a production that I made with Anna Bess and some other collaborators, including undergraduates. And the idea of these vignettes in an unfunded campaign basically is to draw in young people, young adults, to become more aware of the presence of fentanyl in recreational drugs, and also the importance of carrying naloxone on their person. And so I'd encourage you to also view those, and would also welcome feedback on those. We're very lucky to have some support in developing these products, again, from the COBRE on opioids and overdose, and also the New England SAMHSA ATTC programs and Brown Emergency Medicine. So once again, this has been a tremendous pleasure to work with people across all these different disciplines. Think about what engagement might look like. Try to drive people to the trainings and awareness that is needed. I feel like a lot of the work that we have engaged is appropriately focused on people who use drugs, but given the presence of fentanyl in the drug supply, and it's creeping into a whole variety of recreational drugs where people would not really expect it, and also the potency of fentanyl and the need for rapid intervention to prevent harm, I feel like we need to expand the circle of people who are aware of opioid overdose and rescue, so that there's a broader community of people we're reaching out to and getting that highly effective naloxone disseminated. So at that, it's our hope that the addition of IoT modules to NaloxBoxes will support hosts in their readiness and situation awareness, and help support effective rescue in the end. We're also hopeful that these systems will facilitate data collection on the use of NaloxBoxes, and we now have a tool potentially to prospectively investigate how the boxes are being used. I'd like to thank Dr. Randy and colleagues at CDH for this opportunity to share our experiences, and all those who participated today. If you're willing to turn on your videos, it would be great to hear any feedback or questions, and I thank you for your time. And contact me if you like.
Thank you so much, Dr. Capraro. If we could you'd stop sharing your screen so then we can have a discussion. Perfect, thank you. So thank you, everyone. So I encourage you to type in your questions into the chat. And just to get things started, first of all, Dr. Capraro, thank you so much for sharing. That's such a really interesting product. And I'm really curious about the design. So I have a two-part question here. The first question is, you mentioned that you worked with RISD. Can you describe that process in terms of collaborating with, when I say collaborating with designers or kind of the non-health professionals to actually create that, the use design? And then my second question would be, did you encounter any kind of political challenges in terms of, because this is clearly available in different parts of the city, where, like, as a Center for Digital Health, right, we are here to bridge the gap between academia and healthcare, and all stakeholders kind of within the community and kind of the full spectrum. On one side of things, how was it working with designers at RISD, and on the other side of it, how was it in terms of politics or kind of the city, or like whatever kind of challenges that may have been? Can you kind of speak to that spectrum?
Yeah. So yeah, you hit on some really important issues, and I guess one of the kernels of the stuff that I've been involved with really isn't, frankly, highly academic as of yet. Is like meeting up with people with completely different skill sets and totally complementary skill sets. And I think the more we can, I like getting outside the hospital. I like working with people who see things very differently. And so, frankly, RISD was kind of a cold call. I know there were definitely some connections with. Definitely some connections between Brown and RISD. There are several courses. There's Design by Health course that some people tuning in might even be a part of right now. It used to be. So there are some shared curricula. There are some shared research projects. But I think it was actually, I kind of cold called somebody in industrial design, and then she was leaving internationally and handed it off to one of her colleagues in industrial design. And so I think reaching out matters. I think that having some vehicles such as Design by Health curricula helps. There's the Center for Complexity, which has done a lot of collaboration between, I know, emergency medicine and RISD. And so there are several bridges, and I think the more bridges we build, the better. I also should mention Aidan Petrie, who's an industrial designer who had a company called Cymedica, who now runs the New England Medical Innovation Center, NEMIC, down the street from us. And that's also nice, is that we have this geography where we're all kind of almost on top of each other. And so Aidan had a lot of experience in product design and development. And, we're up on like little things like the first prototype that we built with RISD was made out of plywood, so we could understand a shape and a form. And then it's like, well, you have to do injection molding. Well, how much does injection molding cost? So $20,000. Like, well, we're not going to do injection molding. So, so that's when the next industrial designer said, I'm making a trip to IKEA and we're going to buy an $8 box, and then we're going to put plexiglass on it. So, which I think was the most beautiful design yet. So IKEA kind of knows what it's doing too. So I love meeting people with all these wonderful different skills. And I think that the opportunities at RISD are there. I think sometimes it's come in the form of student projects. For this like unfunded campaign, Dr. Sujong Ham was willing to have her students work on a poster type of event to see what they thought would be the design elements that would bring people in to make a person scan something. Because that's another question for me. Like if you have a QR campaign to get people to care or to be moved by a vignette, what makes a person scan something? And I know Steph Brewis is on here, and she's had great success getting people to scan in the ER for food insecurity. So I wonder if can you share something, Steph, that went into your design or implementation that got people to participate?
Yeah, so I don't think I know most people on this call. I'm Stephanie West. I'm one of the junior faculty, PEM faculty that has the pleasure of working with Geoff in the emergency department. Last year, I was awarded an American Academy of Pediatrics Catch Grant, which is a community outreach grant. And we developed an intervention, a screening and intervention for families with food insecurity. So we essentially developed a Qualtrics-based survey, and we made large recruitment posters with a QR code on it. And families, while they were waiting very short wait times to see doctors in the emergency department. That's very sarcastic. They clearly have many hours sitting around doing nothing, staring at my poster. Go ahead and scan the QR code and access a survey. And we've had about 600 families scan the QR code and fill out surveys about their food insecurity, their family demographics. We've handed out subsequently thousands of dollars in supports for accessing food, and we've connected about 100 families with food resources through the state by them accessing this QR code. And it was recently presented at a conference in California, and there was feedback from people that were coming by saying, you know, this is great to have these QR codes. You know, a lot of people have smartphones, no matter what the type of smartphone it is, where they can easily access this, and this type of methodology can be applied both for gaining information from people, but also providing information to people. So it's something that is easy for us to do and has lots of applications in research and outreach, I think.
Yeah, that's terrific stuff. I mean, it's really nice how you engage people and address some, you know, very real needs of our patient population. I think that's something I'd skipped over is just like, you know, the ubiquity of QR codes and smartphones. People are over the hump of knowing how to use them, I think, by and large. And so it's just a way of thinking like, you know, previous iterations were like, well, do we have to install a tablet and a tablet with instructions on how to use naloxone, or no, we need a QR code in the 20-second video, you know? And so I think that this is a nice way we're seeing sort of like of skipping a couple of steps in development and really decreasing the cost of the interventions if we're thinking about doing it broadly. I didn't answer your question about politics. I think we're a very progressive state. I think we saw the curve, the first almost exponential looking rise in deaths was, you know, leading up to 2016 when I was getting involved. And so we were also one of the worst states in that milieu. And so we were suffering badly. Our patients are suffering badly. We needed action. But I do think we have a favorable climate. There were places that I went to. So most of the people you were preaching to the choir, like, you know, you were going to places who already understood how naloxone works, how their clients were at risk. But there were places that didn't want it. So there were some universities I reached out to, and they're like, no, like, and there wasn't like a solid no or get off my lawn. It was like, oh, we have, you know, our security guards have naloxone, or, you know, and so they're like, it wasn't that people didn't care entirely, but there's an issue of optics and there's an issue of stigma, and it's a little bit tough to measure, but we think the physical presence of a box raises conversations and awareness. And if we have other adjuncts in there where people can actually bump up that awareness and knowledge, that's really nice. I'll share one anecdotal thing. There's a healing community study, a multi-center trial for opioid deaths that's ongoing. And some of the interventions, one of the people in that study shared with me that communities could select their own interventions from a field of interventions. They could say, oh, I want to do this, but don't want to do this. And there was a building in Massachusetts, an apartment building, where they knew there were a lot of opioid use and calls for ambulance. They wouldn't accept anything. The only thing they would accept was the community access NaloxBox. And then once you put it there, like our first rescue is actually in the lobby of a building with intramuscular naloxone, which is harder to administer. And the person had come from an upstairs apartment, went down, got the materials, and went back to the apartment and did it. So, you know, if you're walking by it every day, you know it's there, and so, you know, lots of eyeballs matters. So I think the politics are real. I think that you know, eventually, hopefully, build more compassionate environments and make appeals to people's, you know, caring. I think the politics are very real, though. I think it is hard to have everybody on board. But I think the more that it's out and talked about, the better.
Thank you for sharing that. Really, we appreciate that. Mark, if you're willing to kind of unmute yourself and ask your question.
Hey, Geoff. again, like Steph, I don't think I know everyone here. I'm Mark Sanfrillo. I work with Steph and Geoff in the pediatric emergency department. Great presentation. My question is, I know you mentioned you have some initial survey data about the use of NaloxBoxes, and I'm wondering if there's any plan to continue kind of systematic data collection for further peer review publication, just to, get this out there. I mean, in the literature, and sort of further engage folks nationally about these great initiatives.
Yeah, thank you. Yeah, we have the data collected, and we would like to publish it. The response rate was fairly terrible, despite like a multimodal approach to tracking people down. So the 300 buyers, purchasers of NaloxBox 2.0, and we got about 28 or 30 responses, I think. And so it is what it is. We can't force any more responses.
Sure.
I think maybe because there was some hope amongst my collaborators that because it's novel and it hasn't been done, maybe people won't look down their nose too severely at a response rate of 10%, if it's offering something that really hasn't been described real well. For the pilot that Leo and I are conducting, we would like to publish the results. It's going to be a little bit more about like an engineering, design, implementation, the QI process of whether the systems are working. And we'd like to capture some events using QR codes in the box. So you're the facility owner, you get a text the next morning that somebody went to the box. Ideally, you will on your own go inside the box, take your phone, scan the survey with no PHI to describe what the event was. False alarm, vandalized, stuff taken, and was the ambulance called, were reps given, was naloxone given, was an AED used. So it's like a question, I don't know, like 9 questions or something. And if you didn't remember, we'll call you. And so we hope either way we can sort of force that higher response rate. Some environments like Crossroads Shelter, the events are pretty frequent. In a lot of other places, the events, even though they're high-risk populations, are infrequent. We're just being prepared for that one rare, terrible outcome, so people have something in their hands. So yeah, we'd love to do more academic work around this, and there's some data that we'll have access to now.
Awesome.
Thanks for the question, Mark. Elisa, if you're able to unmute and ask your question.
Yes, I'm sorry, I don't have my camera on. I'm feeling not too well right now, so not very presentable for the camera. But yeah, my name's Elisa. I'm a research assistant at the CDH, and I'm actually working on a study right now dealing with substance use populations, particularly patients in recovery from opioid use. So I think, first of all, like hearing about NaloxBox, I think this will definitely be a game changer, especially as it continues to be distributed and refined. So it was really great to hear about this. But I am curious, and I apologize if you have already touched on this, how you and your colleagues, Dr. Capraro, are taking steps to make sure that the larger community, and so these are folks that might not have access to resources or access to medical care, but that the larger community has knows about the existence of NaloxBox, its available locations where they might be able to find it if needed. Just even in our research work, we've encountered a lot of people in the substance use populations who just have so many barriers to accessing things that do exist and things like resources that have already been developed, and yet too many times we tell them and they're like, oh, I've never heard about this before. It's kind of like overcoming that like barrier to just even information distribution that exists in this population.
Thanks for that. I hope you feel better. I'm glad you're doing this work and learning as you're going, as we all are. I think this is where, this is laborious work. I think that for people who are under-resourced, this is where the street outreach is, happening. I think that people doing street outreach in our state distributed either 15 or 20,000 units of naloxone by street outreach alone. And so a public access box is just one small sliver of the naloxone plan. As to how to make people aware of it, I don't know. I think Rhode Island DMAT really hasn't promoted it very much. We had this crazy, weird media blitz that drove the demand. But that's kind of interesting because the demand, was there. It was an unmet need that we, really were surprised by. It didn't have to be the NaloxBox. People have all sorts of other solutions. Some people make little kits and fanny packs, and people have been stuffing naloxone in AED cabinets. There have been all sorts of other people doing all their vending machines. And so, I think that I don't know how to fully address that question. I think about increasing awareness is tricky. I think about broadening the circle. I mean, I think if you have a loved one who's using opioids in a dangerous way, it might not be enough for you to have naloxone. You probably want friends and family or neighbors. It's just the circle has to broaden. I think that the people who do this work are highly passionate and appropriately focused on significant needs that include housing and food and jobs and like real basic elemental human needs. But then also, if it's only perceived as a them problem, then we don't really move the ball. And so that's where I think that some of these more public access campaigns, like our unfunded naloxone is an act of love, is what that link out is on the QR page. And yeah, so I think we're trying to think about that, and I'm not a marketer either. So that's where I'd like to bring in the talents and creativity of people at RISD and Second Act, the theater group.
Gotcha. Thank you so much, Dr. Capraro.
Looks like the next question is from Cicely. Cicely, if you'd like to unmute yourself and ask your question.
Hi, Dr. Capraro. Thank you for the presentation. I'm an intern. My name is Cicely at a CDH. And also this semester, I recently started working with SciTunes. I'm relatively new, so like my drawings are not as advanced as like some of those like senior students. Yeah. But so my question is, like I will definitely look at the SciTunes video they made for the opioids and naloxone, but in your opinion, so you'd mentioned that brief videos are preferred, but in terms of like the narrative or the messaging, like is it preferred to have like more realistic people, like drama? Yeah, so like in terms of like video messages and like multimedia messages, what's like the ideal way to get the message out, I think? Thank you.
Yeah, thanks. I think that's a super hard design question. I think that the SciTunes, pretty serious matter, right? Think about opioids and death and, the public health implications. And so what the cartoon allowed us was to have, you didn't have to choose one sex or sexual orientation or gender or race, you didn't have to have like a single face representing. So, a short clip TikTok might only have 1 or 2 or 3 people, whereas the cartoons, like it's just cartoon figures with a variety of different colors, and we address different religions and walks of life in the video, and so trying to make it really feel inviting and accessible. When we get into the video productions, we had some I don't know, directors' decisions had to be made about who's going to appear on them, unless have a whole portfolio of videos which designed for different communities, different age groups. So I don't know if that totally answers your question. I think SciTunes program was really wonderful to work with. It's mostly undergraduates working with Dr. Adetunji, who's marvelous. And they take some real deep dives. I think just like thinking about modern media, I just think, where's the TikTok and all of our public health? It just seems like there should be so many more ways that we're engaging the public with really quick hitting things. Do we bring comedy into something that's really silly? There's a British CPR video. I don't know if it's called like it's like supposed to be some gangsters, and they slide a dead body in a leather jacket across the floor. Like, you gotta push real hard. They got the chains coming off. It's just maybe you pull people in by something that's really totally crazy silly. So I think you just have to appeal to why are people clicking on anything? Like, bring on the kittens, right? Where are the puppies? So there's got to be ways things that hook people, and I think that some of that can also be anecdotes about success stories. There's something like that where we thought, like, could there be like a share your rescue story? There's some really compelling speakers in our state who have been multiply rescued by naloxone themselves, who now are doing the recovery work and standing up programming. So I listen hard when they talk. What the hell do I know?
Our next question is from Lauren Danzy.
Thanks for looking at that. I'm not watching the chat, so I'm not ignoring people's comments. I can't multitask.
No worries. Oh, Lauren, if you're able to ask a question.
Yes. Hi, my name is Lauren. I actually work with Elisa on some of Dr. Kirsten Langdon's opioid use intervention projects.
Great.
And a lot of our research is built on qualitative interviews, just talking with patients about their opioid use and also their different recovery efforts. And I know that a lot of our questions surround different like harm reduction approaches and sort of getting the word out to patients about different accessible treatments that are under sort of that harm reduction umbrella. And I know that naloxone is such a wonderful initiative for that. And I was just wondering, like, in your experience, how you best suggest like going about those conversations to potentially and hopefully like dismantle the misinformation and all the stigma surrounding harm reduction and substance use.
Yeah, we see overdoses and opioid overdoses in our ER, but frankly, Mark and Steph and I and Sakina take care of the under 18 set. It has ROED, and so it's a little bit weird that I'm doing this work, but not totally, because we had somebody roll up almost dead on our sidewalk suit. So we're not outside of the fray, but we don't counsel a lot of patients this way. I think I've relied, honestly, it's always good to go talk to your target audience and get that firsthand information from people with lived experience. So it's not quite secondhand, but it's sort of like a little filtered. These are the people sitting down at the rescue group or who are doing the street outreach, who work directly with people. So I've even still been a little bit once removed from those conversations, but I do know that, if I'm talking to people who are doing street outreach, who have an addiction, who are in recovery, like that's who I need to listen to. So I think, it's just, if you're starting a social venture or a business or whatever, if you don't talk to your customers, you could be way off the mark on what you're offering and what you think is the solution, because you haven't tried it in the real world. And so as for, you're talking about individuals carrying naloxone, is that the focus of your question? Like what would convince somebody to carry it?
Yes, definitely. Just sort of talking to really anyone that might not be really knowledgeable or interacting in those spaces.
Yeah, I think part of it is like communicating the risk is everywhere. I think a lot of people are really only 1 or 2 steps removed from a person in their life who has an addiction. Maybe it's not an opioid addiction. I think good many of us have been in situations where people are intoxicated to the point of not responding from whatever substance it was. And so I think that as we start to think about you thought it was this, but it really was that, and maybe that conversation. So it depends on the target audience to think that our risk is shared. But I think that the messaging's our responsibility is shared. And so once again, like sort of sharing anecdotes, there's a pharmacy student who was at Women and Infants who carries naloxone because she's a pharmacist doing opioid work. And she'd rescued 3 people in the parking lot at Women and Infants. Like, it's just astounding. And so if people hear those stories, people want to help their neighbor. I mean, we know from sudden cardiac arrest that your chances of surviving a sudden cardiac arrest are twice-fold if a bystander responds, right? And so these are time-critical emergencies where somebody's got to intervene, and most people would love to be that helper, And so, like I said, you first you need to make them aware that it could happen, or they could be the first one on the scene to a person on the sidewalk who really isn't sleeping; they're having another emergency.
Thank you so much. I appreciate that.
Thank you.
Kim, would you like to ask your question?
Yes, thank you for just a really interesting and wonderful presentation, particularly for someone who, doesn't really do this work or really involved in knowing much about this beyond what I've read in the media. I also wanted to say that I've been really inspired about the way that you retooled your knowledge and skills in order to be able to do this type of work. I think that was very impressive, as well as inspirational for all of us who might want to use technologies to solve some problems or issues around health. But I was really interested in the geospatial elements of this work in your presentation of a map. And so I guess I have 2 questions. What are some of the correlations that you might make about where these boxes are located in terms of maybe race, gender, socioeconomics? And then another thing I might, I'm asking, this comes from my interest in digital humanities, is there a way that map that you showed us could be an interactive map that tells stories about where these boxes are located and what happened as a way to raise public awareness. And the last thing I'll say is it's really interesting how these boxes and the geospatial locations rewrites the Rhode Island, rewrites the sort of the understanding of it, whereas people might use a map for tourism or other things to do in the state, you're sort of recasting the state and the cities and the area in that way. So I just really impressed with your work.
Oh, thanks. I mean, we are very rich in our state with people who are diving deep into the epidemiology, and even with the COVID response, we was working with some community groups and thinking about cold spots for immunization and hot spots for outbreaks, which travels with a lot of social determinants of health. I think that there's this street knowledge of people who do the work, who go to the places where people are, and then there's numbers, and I think we need numbers. We will not find even though I said count on your people who are doing the work, they're biased towards the work that they did the last 3 years. This epidemic is shifting. The stimulants, African Americans and Hispanics, are being clobbered by opioid overdose relatively to where they were before. And so if you don't have the hotspot map, you are not going to intervene in the right places if you're just going on your previous network. Is the epidemic shifting, week by week? I mean, some would say it is. I think that I'm talking about more like, I think a year-to-year change. Like, over the years, it's shifting because probably because of the fentanyl variants that are in the drug supply, and partly because of being mixed into a whole range of drugs. And so who's taking cocaine thinks that they have fentanyl in it, or who taking ecstasy thinks that they weren't thinking of it. They didn't think they were going to be knocked on their fanny from a occult drug. And so what you hit on is totally essential. I think that we need to be looking at those maps and re-looking at them. And we have the power and we have the people, like at our Department of Health and probably a lot of others, to have robust heat maps to where we should be going. We have something called the ROAR report, ROARR, and I'm forgetting what it stands for now. But there's sort of like an expected number of overdoses in a region in Rhode Island. And if you're up over the threshold at any time, it sends off an alert for street-based intervention. It's not down to the neighborhood or the street corner, but it's in that area. So the state has an active surveillance and intervention program that might not be totally, I haven't traveled with them, but it might not be down to like this, this corner, but it's kind of working on that epidemiology. And so your comment about interactive maps is great. I think that that's what we were thinking much more simply, like we should have a photograph of where it is in the lobby, but to have a story about it is really, really a great idea. And the technology, like, give me everything Waze can do, please, and so it's nice to think about an interactive map. And I had one conversation at Rhode Island Department of Health. There was a person doing ArcGIS work where they're trying to input the AED locations and NaloxBox locations, because we had the 60 or so NaloxBoxes we installed in 2017, but then there was something called the Code project, where communities could select different interventions, and there were a lot more NaloxBoxes. This is one thing, like who's at the helm, who knows what's going on or where things are. And so there has to be an onboarding process there if you haven't done it prospectively to onboard all the prior units.
And no issues about surveillance, and I don't mean in a public health way, but police where, it may be all right to use the intervention to save a life, but then there are correlating issues with that person, maybe, warrants out for their arrest, that use of it brings that visibility to the authorities. I didn't know if that was something.
There's always that fear, and that's why, if you have a signaling box, do you want to call 911? Most people we talked to said absolutely no. People, even if there's a Good Samaritan law, they're concerned that there's criminal activity in the area. We're using substances that are not, DEA approved, and so absolutely, that's a big issue. We didn't hit upon it in our installations that I was aware of. Some places wanted to even put the boxes where they knew there was a security camera. I'm not sure why. When we launched it unlocked, we left it to be determined whether people would take the naloxone. In Indiana, they're doing a statewide implementation in every county where they're using it as like a Pez dispenser. They're like, we're going to stuff this box, not with 2 boxes of naloxone, but as much as we can put in the box. And if people need it, they'll take it. And if they took it, that means that's a place that didn't have enough, right? So that's kind of how we launched it. Once again, not having the retrospective data or any real situational awareness, but a feeler, to say, yeah, well, we hit up on the right place here. And now maybe we need to do additional outreach. There's probably a need for needle exchange in this neighborhood that we didn't know about. There's things like that. So the surveillance question is really important. I'd love to know more about what you're thinking about the interactive map, because it sounds like you have really a compelling put a humanistic face to these tools.
Yeah, definitely. Can I take, I don't see any more questions. I just want to ask one more question. Is that okay, John?
Please.
What advice would you give people who maybe 6 or 7 years ago were in a similar position where they didn't have necessarily the technological skills or even know the various people on how to get started to build something to solve a problem like this, or not like this, but a problem, a social health problem?
Yeah, that's a great question. I think that this work has been so collaborative, and Leo's on the line, and Leo's a emergency medicine physician who has engineering skills, who taught himself to code when he didn't know how to write the software. This is I think about, like, sometimes, like, think about our centers, the undergraduate campus, the public health campus, the medical school. There are so many bright people, and I think almost like I think of it as like resources that need to be disseminated or extracted from the university and put into where we live, because it is very rich. As far as like getting going personally, I think we need to just, it starts with me. I always trying to actually think about ways that I could do. I had gotten away from volunteering a good amount, and I was trying to think about an activity that had volunteering but also could bring in some content knowledge that I had. So I think it's good to map maybe where your passions are, and maybe if your skills could be used, or your skills or colleagues or people you reach out to could share that passion. And then also think about, if you have special skills, you might have something more to offer than just pure labor, right? So you're a mathematician, or you're a singer, or so I think it's always nice to think about, like I think about, like, our extracting, it's terrible to think about, but like our university is very rich. So how do we pull all those resources into good causes, and so that's kind of, I'm very thankful that I had the ability to engage all the people I have, and I think that they don't feel like they're happy to give what they have.
Thank you so much, everyone, for your questions. Such an enriching conversation, and I want to thank Leo as well for typing in a lot of good content and answering a lot of the questions as well. Dr. Capraro, thank you so much for presenting at this seminar. It's been such a pleasure to learn more about NaloxBox. Thank you, everyone, for attending. We have our last seminar of the semester on November 2nd with Dr. Michelle Ibarra, and look out for an email for that. But thank you, everyone, for joining us again. We hope that you have a good rest of the day. And Dr. Capraro, thank you again.
Thank you for all your great questions and participation.